if you were to institute this tomorrow, when would you start checking ESR1 mutation?
Yeah, it's funny you asked that because I'm such a high utilizer that, like, if a patient had been in an aromatase inhibitor previously, even if it wasn't in the past 12 months, I do tend to check, at baseline for ESR1 mutations because I never want to be utilizing a therapy that the patient is resistant to. And so I would rather know immediately. So if there's any exposure to a aromatase inhibitor in the past, I do check their ctDNA because I like to check that at diagnosis of metastatic disease. And so it wouldn't just be after 6 months on an aromatase inhibitor for me. And then right now, I've been thinking about the patient's symptoms and their tumor markers and their labs and thinking, using that to help me decide when to order ctDNA. But who knows, in the future, maybe I'll use a ctDNA to determine, the reverse if the quantitative measures are going up.
Right. I think that's the issue because when you get your next generation sequencing, you don't get the quantitative value.
Exactly.
So right now there are two separate tests. So that's why the real question is, when would you send to look for mutations? And so if you forget the first line part that you already did, when would you start doing it as a repeating test? Would you, or would you just do it at a certain point because the patient had pain or something else?
Yeah. So in the SERENA-6 trial, they measured it every 2 to 3 months. That is a little more frequent. I am concerned about costs. We don't know the insurance coverage of all of this. In the United States, that's an issue. Of course, in European countries, not so much if it is accepted. And so I haven't really figured out how frequently I would utilize this as far as would I do every 3 months, or is in certain patients 6 months okay because they're doing so well.
And have oligometastatic disease or something. Yeah.
So
There probably will be. I will have to individualize to some different.
that tends to be my practice in general, is individualizing based on the patient in front of me.
And then, the one of the ideas is that, the same kind of thing that's been done with triple negative disease has been done with HR positive disease, where you get, 17 to 18% of patients who don't go on to each subsequent line of treatment.
Yeah.
At all, actually, which is amazing. But also there are patients who go on to chemo or ADCs in the second line setting. So do you think that I think it's a question about if there's a delayed time to chemotherapy, could we, by treating before there's true endocrine resistance, just the ESR1 mutation, so by changing earlier, could we delay that time?
Yeah. And a lot of that, I think, really depends on that disease biology. Those ones that are going to get that ADC in the second line setting are either your endocrine refractory patients or just really nasty disease biology in the luminal B setting, for example, that you're really worried because the patient has a really big liver burden. Those are the ones that you can lose super easily. But I am intrigued, and I like the idea of sort of delaying that potential disease explosion too. There is a patient population too where when you start to get this expansion of the mutational profile, their disease they get the liver mets.
Yeah.
And then once that happens, that becomes the focus of everything that we're doing. And so if I can delay the onset of very serious visceral disease with medicines that provide a good quality of life, that is certainly desirable, in my opinion.